All right, everybody, it is about that time. I'm first of all going to thank Medtronic for sponsoring this expert roundtable. I am actually hijacking their webcast. It is being streamed right now. They're getting ready, and I've got them in my ear right now. As soon as they start, I'm going to bring them on. This is going to be an expert roundtable on telemedicine, telehealth, and strategies to manage your practice during the COVID-19 crisis. And if you guys have any questions, I will try to, type them up in the comments, and then I'll try to ask in the live stream. If you're not logged into the live stream that is on WebEx, you could do that too. But you should have gotten or logged in or signed up a few days ago when I made the announcement. But if not, you are still going to be able to view the roundtable, and this will be saved on Facebook, so you'll be able to see it on replay. If you guys have any questions, again, leave them in the comments and I'll try to answer them or ask them on your behalf. I'm sure there'll be a lot of people joining, a lot of questions. Can't guarantee that they'll get to your question, but I'll do my best. Hopefully you guys are doing okay and doing what you can to mitigate your risks and protecting your staff and protecting your practice. I feel extremely fortunate in that my staff and I have been very, very progressive in looking at office operations. Is a very, very small practice, so we've always run extremely efficient. Transitioning during this crisis is actually pretty darn seamless. I'm very fortunate in that I've been doing video for a while. I have this whole setup, and I'm comfortable in front of a camera, and I know how to work the hardware. So I'm also very grateful that I can bring this to you because of my knowledge in technology and streaming on Facebook. So they are still getting ready. If you guys have any questions right now, please leave them in the comments. I'm using a new streaming platform on Facebook, so hopefully I can see your questions and comments. Looks like they already have several questions being asked on the WebEx. They will be answering questions at the very end of the broadcast. Yeah, I don't know why they don't make this widely. Well, I guess they are making it widely available. They're just making you sign up, collecting your email and your demographic information so they can sell you stuff later on. I guess that's fair, right? They're providing this value to us. It is fair that they collect our information, I guess. That's a small price to pay. Looks like we have quite a few people joining. Yeah, Facebook is constantly improving their video platform, streaming platform. So I'm using their producer, Facebook Live Producer. It's a new way to go Facebook Live. And I'm checking the stream. Everything is looking great. Based on my reading, and believe it or not, I read every single one of your posts on the Thriving Urology Practice Facebook group. Based on the responses and the questions, when it comes to telehealth billing and coding, there's no one right way. Medicare will tell you place of service 02, and you submit the bill, but your MAC may not be ready to receive 02. Some private payers, Medicare Advantage plans, may want a place of service 02 and a 9921X and a modifier 95. I've also read some payers want a place of service 11 and a modifier 95 or modifier GT. So it's all over the place. It seems like it's trial and error, kind of like introducing a new code or new line of service, and you are now billing the payer. Payer has to catch up. They need to get their head out of their butts and get things set up. And we, unfortunately, is just trial and error. So it may be frustrating, but we'll get through this. At least you have the information, you have the knowledge. It's either place of service 02 or 11, depending on the payer, and modifier GT or 95. And Marina said, one of the members on the Thriving Urology Practice Facebook group said that they have to use some crazy modifier, PJ1, PJ2, PJ3. I've never heard of that. So your institution is different. They may have a special contract with the payer. It might be a hospital. I don't really know. So looks like they're starting. I'm going to switch on over to stream.
on where you are in the country. My name is Julie Cole. On behalf of Medtronic, I wanted to thank you for joining our national broadcast. Today's topic, telemedicine, telehealth, and strategies to manage your practice through COVID-19. We have two speakers today that I am pleased to introduce you to. The first is Mark Painter. Mark is CEO of PRS Network. PRS stands for Physician Reimbursement Specialty.
And he needs no introduction.
He is a known expert in the field of reimbursement and policy. He's a frequent speaker at urology national societies and also a frequent publisher in the Urology Times. So Mark, we're glad to have you and your expertise today.
Thank you, Julie.
Our second speaker, absolutely. Our second speaker is Dr. David Ellis. Dr. Ellis is a practicing urologist. He is also chairman of the executive committee for Mid-Atlantic Urology. Mid-Atlantic is in the greater Philadelphia area. And Dr. Ellis is also a board member of Webcast. Dr. Ellis and his practice were very quick to adopt telemedicine and telehealth strategies when COVID-19 hit. So we invited him today because he has a lot of practical knowledge and experience that he can share with this group. Now, today's broadcast is being recorded. So if anyone is unable to join live, we will be sending out the recorded version within a few hours of the broadcast.
Too late. You're watching it now, and you can watch it right away.
On entry. We did this to try to prevent some of the background noise. You will be able to ask questions. In the lower right-hand corner of your screen, there is a chat feature. Please feel free, as we have questions throughout the broadcast, to enter your questions into chat. At the end of the broadcast, we will take all of those questions and leave time for Q&A. So without further ado, Mark, I'm going to turn it over to you.
All right, very good. Well, thank you, Julie. All right. So first, I will tell you that this is a fluid situation. And in fact, we actually had to change the slides this morning as we got some new information coming across the desk. And for those of you who are out there and actually seeing some of the questions coming in so far, know that we're giving you what we've got right now, and we're trying to collect things and ultimately really appreciate that a lot of people are sharing information with one another and with us, and we're all trying to put information out there as fast as we can to help everybody keep up. So here's what we know as far as the latest. First up, just to make life easy and to kind of separate things, I'm going to use telemedicine and telehealth to describe two different types of services that you can provide. Now, you'll see that telehealth really has a broader meaning across the board, and it gets used to describe both telemedicine and telehealth the way I'm going to use it. But really, what I'm just trying to do is give us some context as we get through this. So first off, telemedicine, which is audio and visual. So this would be a live interaction with a patient remotely, and that is using audio and visual both. So you have what they basically a synchronous data exchange. So that's what I'm going to call telemedicine. Telehealth, I'm going to use to describe asynchronous informational exchange, which includes audio, maybe separate from the other information you're dealing with, which would be like a telephone call, and those interactions that occur through other telecommunications like a web portal or secure email. So those are those types of interactions where you don't have all of that information kind of in front of you at the same time. So that's how I'm going to split it up today. I know that gets used differently in different places. So we're going to start with talking about what happens now in the current environment with telemedicine. And this is, again, when you use both the audio and visual to interact with your patients. Now, yesterday, the AMA put out some information, and you can find it on the American Medical Association's website, that talks about some of the interactions they've had specifically with CMS to clarify their emergency action protocol and some of the information that was put up on their FAQ page. This information yesterday really clarified that CMS will not enforce the requirement that patients have an established patient or established relationship with a physician that's providing telehealth. Now, again, we're talking about both telehealth and telemedicine and used in what the AMA's context is. But what this really does is clarify one of those areas that we were kind of tiptoeing around, which was you can provide telemedicine services or bill for new patient visits for patients that you have not interacted with prior. So it opens it up for both traditional Medicare and Medicare Advantage programs officially, although a lot of Medicare Advantage plans had already opened up the ability to charge for telemedicine visits with new patients. So that was good news. And actually, we have also some confirmation that some of the physicians have called and obtained direct written confirmation that some of your Medicare carriers, your MACs, have already acknowledged in writing that in fact you can charge for new patient visits even without a prior relationship with a patient. So it always feels good to have that in writing. The original FAQ kind of made it more like a wink, wink, nod, nod, go ahead. But you know, you like to have it in writing going forward. So you can charge for those visits. That's the 99201 through 99205. For your established patient visits, these are your scheduled visits. You can use the 99212 through 215, again using audio visual. They have also clarified that the place of service is going to be the office when you look at it from the NPI-2 side. And for those of you who don't know kind of NPI-1 and NPI-2 numbers, your facilities that you provide services in, your office, your ambulatory surgical center, and your hospitals all have an NPI-2, which is really an NPI number for a facility. So, and they all have associated addresses assigned to them, which go out with the bill on the 1500 form if you're printing it, but within the electronic fields if you're billing electronically. So what they did clarify is that if you are providing telemedicine services from your home, the place of service would be O2, but the actual NPI-2 is your office or what is registered at your office. So you don't have to go in and try and get an NPI-2 for your office. So your system should all be set up to do it this way. I know that a lot of the electronic medical record companies and the practice management systems have been scrambling a little bit to get the O2 in some cases. A lot of them had it in the system, but maybe not assigned within your practice. So you may have to do some setup within your billing system and within your electronic medical record to actually communicate the appropriate place of service of 02, which is the appropriate service for billing Medicare and or place of service for Medicare and Medicare Advantage plans for all of your telemedicine visits and your telehealth visits. So that basically says you didn't provide the full service in your office, but that the patient was at their home address. Now, this was a little bit of a change overall, and of course, those of you who practiced telemedicine before or maybe thought about practicing telemedicine before know that Medicare required the patient to be in a specific facility, and that has been officially waived. So you can provide services to the patient in their home or where they actually have access to telemedicine visit technology. So we do have a few discussions points a little bit later for some of those things that don't go exactly the way we expected to, because of course that happens. Now the other thing that CMS did do was they opened up or relaxed the HIPAA rules slightly to allow you to use FaceTime and Skype to conduct these visits, even if you don't have a business associates agreement. Now, I'm going to encourage you to be cautious anyway with HIPAA. I'm a little bit more tight on the HIPAA requirements than a lot of people, and I do encourage you. There's plenty of services, and we'll show you a list in a minute, that are fairly easy to download and fire up without a lot of difficulty and easy for patients to use, that are HIPAA compliant and are ready to go and are much better to use relative to FaceTime and Skype. So if you can, we encourage you to use HIPAA compliant software. If you can't, patient care is the #1 issue we're trying to deal with here, continuity of care. And that's really where these moves are coming from in the era of social distancing, or in our time frame of social distancing that we're observing right now. So if you have to use FaceTime or Skype, you can do that. But again, if you can implement HIPAA compliant services, you should. Now, the second set of services we'll talk about are going to be your the telehealth services. And again, those are your web-based or your phone-based visits. Okay. So when we look at some of the billing requirements across the board and the documentation requirements, looks like we got an extra one in our level 5 visit. Sorry about that. But your new patient visit codes, which are 99201 through 99205, still require 3 out of 3 for the documentation rules. So remember your 3 components of history, physical, and medical decision making. And they need to meet or exceed the level of service that you're charging, and they have to be documented in the medical record. Now, we expect that a visual physical exam is, in most cases, going to be lower than what you would typically do in an office-based setting. So you want to be a little bit careful of using your templates, because you're still going to want to document each one of these visits just like you would an in-office or a face-to-face visit. But your templates may be set up to drive your physical exam in and provide some things that actually you're not doing in your telemed visit. So you're going to want to be a little bit careful on how you use those templates. Now, there are things you can visually inspect, and I'm just going to give you some examples of things that could potentially be done on a physical exam for a new patient. You know, if a patient has their own thermometer or blood pressure cuff, you may be able to have the patient take those while you're on the phone with them and report those to you and record those. You can certainly see if notice the patient's general appearance. You've got alert and orientation, so you've got some psychological and the neurologic systems that can be easily addressed. You can see if they're ambulatory or not. You can tell if they're obese or not. So there are a lot of things that you can observe via video that can be added into that physical exam that would potentially pop you up maybe to a level 3. I have not yet heard of anybody doing the full, strip down and let me see everything physical exam type, but there are no specific blocks for that. I'm just urging you to be cautious and do what's medically necessary. Now, the time-based billing is still in play. So if you do spend that full amount of time and you record your visit based on the time that you spend, and I think we're hearing right now that there is a fair amount of time going into telemedicine visits right now, time-based billing does not require that you have the history, physical, or medical decision-making. So with your new patients, you do have time, or you have the 3 components, and again, document it like you would any other visit, but be careful of your template. Established patient visits, you may remember, now they can be billed also. Remember that they're 2 out of 3, so you don't need the physical exam. You can update the history, document the appropriate medical decision-making, or you can use time. So it's 2 out of 3 or time for those visits. So those may be a little bit more like you would normally see in your office-based encounters at 3 and 4 for a lot of those patients. And there's, of course, going to be, with the increased amount of time you spend, a few more 5s. So you do want to document as you normally would. Kind of, I mean, in the end, what this is a substitute for your in-office, office-based billing, and document appropriately. Now, Medicare says that you would use the place of service 02 in addition to those codes, and that's all you need to report. No modifiers are required. That is true of Medicare Advantage plans as well. The modifiers that I have listed there for private payers, and I'm going to add one more to the list that I just got an email on, which is the GQ modifier. So there are some payers that are out there that aren't really set up to deal with the place of service 02.
Surprises no one.
Couple of reactions we're seeing. Some of our payers in some parts of the country are telling you to hold your claims until a specific date, probably to get their programming set up so they can accept the 02. That means you might see some rejections right off the bat of when you submit these claims. At the clearinghouse level, double check the websites of the payers if you can. And that really is probably the best way to deal with some of your payers right now, because their phone lines are full and they'll probably reduce staff as well as they're trying to do with social distancing. So check their websites as you can. Be patient. If you can get information from others or from the payers, please share that around, because again, everything is a little bit slow,
especially on the Thriving Urology Practice Facebook group.
Private payers, when you're billing these codes, I would say the majority of them that we're seeing are allowing for telemed visits, just like Medicare, for the new patients and the established patient visits. Not all of them. There are a few very small payers that are still requiring the 99241 series of codes for telemedicine visits. So those are still out there. And then you have some payers that may not be able to make the programming change to the place of service 02. Those may still require place of service 11. And as I mentioned, the GT modifier, the 95 modifier, or I'm going to add in the GQ modifier for services that are provided. Now, the other thing I'll add in here is that there are a number of the payers that have opened up billing for these codes, even if you don't have visual. So you can bill with some of the payers with just a telephone interaction for both new and established patients. So you're going to want to watch your payers specifically as to what they can and can't do. The next thing I want to talk about briefly is copays. Copays really are an issue right now. A lot of your private payers are saying that they're waiving copays, and that in fact they are going to be paying you in full and basically waiving the copay from the patient's responsibility, but not in your reimbursement. Not all of them are doing that. Medicare specifically has said that you can waive the copayment, and if it's a barrier to care, you're going to want to do that. But we are going to encourage you to be consistent about whether or not you're going to waive those copays. Finally, I'll mention that you do want to think about the forms, especially for new patients that you normally obtain. Things like your financial, your HIPAA, and your telemedicine release policies. If you can get your patients to go on your portal and fill those out, that's the best possible method. But you can email blank documents to them and encourage them to either upload them to the portal or sign those and get them back to you through secure messaging, or as a last resort, have the patients kind of take some pictures and send them to you so you have those records. And then the other thing I'll put in play is, if all you can get is a verbal consent, actually explain to them the consents that you need, and document that you did that in the patient's medical record. All right, so here's a list of some of these, and Julie, we are supplying these slides to everybody after it's over, correct?
Correct.
Okay, great. So
or you can watch it within minutes after this live stream concludes.
That are out there that you can look at, and there are a number that are actually fairly easy to adopt. We've seen a number of of folks grabbing new things and throwing them up in a couple of days, and patients using them very quickly. So this list will be available to you. I won't really go through all of the information that's there. And just to close out, I did want to touch a little bit very briefly on the telehealth side. These are codes that can be used for the top two for telephone visits, asynchronous telephone visits, the check-in visit, the G2012 and the G2010 really should be initiated by the patient. If you can advance the slide a little bit, there's another box there, thank you. They should be provided to established patients. And ultimately, when you talk about things initiated by the patient, what we're saying is the patient called and maybe they asked to speak to the physician. You can actually schedule the return call. That still counts as patient initiated in that visit. So you don't have to have a physician or a nurse practitioner sitting by the phone waiting for phone calls. Those can be handled and rescheduled, although we do have some folks that do have and are doing triage right now with their NPs or their PAs. So there's a lot of different ways you can set that up. The 99421 through 23, those are interactions through the patient portal. Again, they should be patient initiated with established patients. They're a little bit different in that they add up, they include all the time that you spent over a 7-day period in interacting with the patient to deal with their patient care. Essentially, those interactions are going to be recorded in your patient's medical record. If they're in the patient portal, all the interchange is going to be there, but you may want to put a quick summary in the patient's record so that you can see that for continuity of care and care that's provided by some of your partners. Those breakdowns of those visits are 5 to 10 minutes, 11 to 20 minutes, and 21 and over as the different levels for those particular codes. Now the G codes, those are the services that are provided by the staff. Typically those would be nursing visits in your office, so they're fairly low-level interactions with the patient. And they don't really involve much more than checking with the doc or the mid-level to actually provide the answers to the patient. Now, the one thing I do want to make sure you understand is that as you look at time adding up for 99421 and 23, you're not going to add in your nursing or staff time. That only really counts the mid-level or the physician time that's spent dealing with the patient for those two. Again, those things, because they're patient initiated, CMS has relaxed specifically that you can encourage your patients specifically to initiate these phone interactions or these web interactions. You can message them in a number of different ways. They can be broadcast emails. You can message them when you do the appointment reminders to let them know this is available. So you can really encourage your patients to contact you and utilize these services. Now, the one thing I'll say really quickly before I turn it over to Dr. Ellis is we've gotten a number of questions about what do you do if you're trying to do an audio-visual visit and the patient is incapable of turning on the video portion of this. Right now, what we're saying, and we don't have overall official guidelines relative to this, but in the spirit of what they're trying to do, what we would encourage you to do is to document that you made the effort to make this an audio-visual visit, and go ahead and use the evaluation and management codes, including the documentation that you were unable to establish the video for this. Nice. And as long as you can provide appropriate and adequate care, go ahead with those.
Nice.
Dr. Ellis.
Hey, thanks, Mark. Good afternoon or good morning, depending on where you are in the country, everybody. I want to thank Mark. He comes from a real urologic family. He has it in his blood. His dad was a big deal, and Mark is carrying it on, and I appreciate it. So I salute you. This is going to be the meat and potatoes portion of this particular conference. Look, we are all confronted with this. I'm just outside of Philadelphia. This is a hot spot behind New York. We're probably 10 to 14 days behind them. Patients are starting to fill up into the hospital. We've canceled elective surgery. It is a scary time, but we'll get through it just like everybody else. And so I remind you that on the phone call that this telehealth business can be a way to take care of your patients and keep your practice running while we're in the middle of all this turmoil. Telehealth started out for rural care. A patient had to go, 3 counties away in some rural designated area, go into some clinic, and then the doctor from Philadelphia could call in and with an audiovisual technique be able to interact with the patient, and that was billed as an office visit. The rules have now truly been relaxed, and Medicare gets it. They don't want patients traveling. They want the patients to stay in their home, and they have relaxed those rural care telehealth rules for us. The very bottom line is that we can, from our office or from our own home, talk to a patient and use telehealth and be able to bill an office visit straight on. And it is a way to have continuity of care for them while they are still at home. So what do we do to make that set up right now? Mark already gave you a list. You see it on the slides. There's plenty of technology that you can use. It has been my own experience in Philadelphia that most of my octo and nanogenarians don't even have a flip phone, let alone a computer. And so they're not going to be able to do the visual part. But I did find some information that was available from the Office of Civil Rights, which really regulates HIPAA. And they say, so long as you're making a good faith attempt to do audiovisual, they're not going to ding you if you do audio. I have that for right off of their website. But as Mark said, this is a very legal, fraught issue. So you want to make your best efforts to communicate with the patient through both audio and visual. But if you can't, and if they can't, the patient care trumps everything. So you got to take
just
care of the
document that
patient.
in your chart.
Okay. So how did we do this? Really, you get on the phone, you have to let the patient know that this is an official visit. They have to give their consent. You want to make sure you document that in the notes somewhere. For those of us who are on your chart, and I understand, at least 20% of urologists are, we just made that a chief complaint button. And it says right on there that the patient gives consent and that we're doing this because of the national health emergency. As you go through, you're taking your history, review of systems, review the drugs. You can have your staff do it. In my office, staff are calling patients and letting them know that, no, we're not canceling your visit. You just stay by the phone and give the doctor about 90 minutes from your appointment time. He'll call and you'll go over things. Some patients are thrilled. Actually, most patients are thrilled with that alternative. Most of them who were calling to cancel are very happy to hear the doctor's going to call. I warn you that when you do call patients, they've been cooped up and they're thrilled to talk to you. They're thrilled to talk to the doctor and they don't want to get off the phone. So you're going to find these visits take actually more time than they might otherwise have in the office. Nevertheless, you run through your chief complaints, review of systems, through the drugs, all of the histories. You're not going to do much in the way of physical examination, and you're right down to medical decision making. You're charting a note, and then the billing merely ultimately is the same, except the place of service is O2, which means telehealth, instead of the place of service being 11, which is your office. But you are still using office codes, all of the new patient codes and all of the established codes that go with it. And as Mark said earlier today, Medicare clarified that you can actually see a new patient through this technology, and I have done it several times, and the patients are really very appreciative.
I'm going to have to disagree on
PSA
this taking
really
longer.
wants to hear from somebody, doesn't want to sit around. And so this has worked out. Now, how do you get that going in your office? It's a completely different workflow. I'm used to walking into an examination room and grabbing a stack of papers that have already been printed out, even though we're electronic. So I get to see a couple of the past visits. I have a super bill if I need to be writing some notes, even though we're billing electronically. And I can lay it all out with the patient. Well, the key is to have exactly that same information put together for you by your staff before you get on the phone so you can get through to these folks. The phone call takes longer, in part because that first 3 to 4 minutes is really about the state of the world. Everyone wants to talk to you about their
Not necessarily
concerns
true.
and the anxieties and whether they were in World War II and they've seen this, or if they've never seen this. You know, it's an issue. It's a social issue, and you're kind of their lifeline. And so you really want to take the time to do that. But you document your note, and then off it goes, and you get right on to the next one. It took us several days for the staff to understand what the new reality was. And as we look at our schedules going forward, we first had a number of patients calling to cancel. Then we immediately changed the script, if you will, to say, no, we're not canceling. The doctor is going to call you. And then that stopped that hemorrhaging, if you will, from the office. And now we're calling patients a week ahead from the staff days for the staff to understand what the verification and the referrals and all the demographics that we typically want to verify when they're here in the office. And then they know that sometime later in this week or next week, the doctor's going to be calling them at the appointed time. It is truly working out. We'll see what it means. Everybody is concerned. We know that it is absolutely a loss of revenue. It is the codes that you may be billing are a little harder to achieve at high levels because of the lack of physical exam. And there are all the ancillary types of things that you might be doing if you used to doing a urine analysis, ultrasound, urodynamics, cystoscopy, whatever it may be. That's not happening. So it is a challenge economically to your practice, but it's a way of keeping your practice afloat until we see some relief from Washington. We all understand the bill did pass. Nobody knows exactly what it says. And as a shameless plug, I know that we have a webinar with LUGPA tonight, or at least it's an audio phone call tonight. And there's been an announcement set out that I expect will give us some better detail on what that means to our practices.
Hey, Dr. Ellis, really quick, would you mind going through the slide here and telling us how you're prioritizing patients?
This is Julie trying to keep me on script, which is fine. I'm happy to do the slides, but I wanted to make sure everybody really knew. Okay, so slide number, wherever we are, 7 or 8. This is a script for those of you who are trying to sort it out. You can clearly see this is what your secretary can say. And I don't need to read it to you. You can all get the sense of it. 90 minutes is key because it's very difficult to predict the time that you're going to use for that individual phone call. Number 2, I wouldn't concern yourself too much about this. We started to look at the schedule and say, gee, this person could be rescheduled. This one's got to come in today. And this one's going to be telehealth. Now, all of them are telehealth. And for the patients that object, and they say, no, I must see the doctor. He must feel my prostate. That's fine. The doctor's going to call you. He's going to discuss it. And if he wants you to come in right now, we will have you come in. And then that tends to calm everything down. Tips on integrating. So yeah, we had 20 minutes of setup time just to make this work. For our audio visual on this national conference, and it is very difficult with patients. And I must say that much of the time there isn't a visual opportunity, but they are all able to use the phone. And so we are calling them with audiovisual capability, but wind up using the phone for the most part. What else would you like from me?
Not my experience.
Yes. Okay, we can go to the next. Unless there was something you wanted from there, Julie.
Yeah, I think, Dr. Ellis, on this, one of the things you mentioned to me is that you're having your MAs and RNs engage the patient a day ahead of time to make sure they have that video or audio connection.
100%.
That you're performing medication reconciliation and review of symptoms ahead of time so that the doctor's time is spent really just on that
ding, 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 ding,
as needed.
Just like in real life.
Reminder, it is true, and that's part of the workflow change. The MAs that used to do that pre-visit stuff when the patient first enters the office are now doing that on the phone. There was some confusion. Everyone was worried, gee, I'm calling the patient and then I've got to do all this and then I've got to hand you the phone. No, you don't. It's 2 different phone calls. And that way it's much easier on everybody.
Excellent.
Want to flip them? Okay. Let's see. This is worthwhile going through. The staff is scared. It is a very fluid environment, as Mark noted. the recommendations from the CDC are changing sometimes more than daily. We're getting a lot of our lead and analysis from our local hospitals. And what we have boiled down to right now is that in order to keep the staff safe and keep the virus out as best as we can, we want to reduce foot traffic immensely. I work in a clinical environment where more than 300 patients come in a day. We're now down to less than 15 patients coming in. And those that are coming in, there's a few that are getting a hormone injection that are due or overdue. There's a couple of cystoscopies for bleeding getting done, catheter management, but that's really about it, unless, the very rare biopsy for a difficult circumstance. We are keeping people out.
I'd love to hear about that circumstance.
This telemedicine enables it to work. And instead of trying to reschedule everybody in 3 months when we already have a full schedule, this keeps the flow working better. So regarding safety of the patient, we're wiping down everything. There are 1 million signs starting from the front door in the parking lot, in the elevator, on the elevator, and at our front door. Don't come in if you have a fever, cough, or travel history, the usual business. And we're also greeting everyone with a medical assistant who's taking everybody's temperature, including the doctors, including all the staff, and including our visitors. And that gives everyone a sense of security. We were not wearing masks. We are now wearing masks. And we're doing that when we are in the hallway talking with people. But I don't do this when I'm using telehealth, obviously. So the reason for the mask, as I understand it, and this is not my area of expertise, but in South Korea and in Singapore, they did well by putting the whole population under mask, because while it doesn't keep you from getting the virus, it keeps you from giving the virus. And so there's some benefit there. So everyone's getting a mask and they wear it all day long as we have those masks. Let's see. In the waiting room, social distancing is being practiced. It's helpful as you're spacing patients coming through the office. And you can keep them a good distance apart. It's one thing when there's 300 a day. It's another thing when there's 15 or less. Yes, spouses outside. If they come to visit, they get to wait in the car. We're trying to really reduce the foot traffic in the office, and cleaning off the tables and the pens and your freezer if you use it. You just got to be vigilant. I already covered much of this. I believe that we're about 80% capacity from where we had been, which isn't bad. And that's using telehealth in place of our office visits. We have rescheduled some people are just concerned. And a drop of revenue, this is a guess, we don't really know. We're like everyone else, we're still collecting last month's AR, not last year's. And we think that it's going to wind up in this area. And that, of course, puts significant strain on all of us administratively. How are we going to manage staff? How are we going to manage our practices? The doctors have seen stuff like this before in their careers, so they might be a little bit more relaxed about it. I don't know. Certainly the ones around me are relaxed, but we'll see. But part of your opportunity, and I see we have 500 people on this call, is to demonstrate leadership, calmness, consistency. People need stability in the time of change. And if you're attending this call and you're interested in it, I must say I spend much of my day calming people down and making sure everyone knows the world's not falling apart. It's just a change of routine until we get back to normal.
100%. Agree.
Let's see what else. Staffing going forward, that's a big issue. I'm sure everybody's internally evaluating that. I've heard of a number of practices that have laid off very significantly. A large group laid off 75%. I know of a a GI practice that laid off more than 75%. We have had a little bit of layoff, but I understand by rumor only that the legislation that was passed last night into this morning may set a different circumstances for all of us, but I cannot speak authoritatively to it. But I would make sure you learn about this quickly because it will make a difference. What do we have? Is that it on the slides? Excellent.
That is it on the slide.
All of that so that we could get to Q&A, because I expect that's going to be pretty robust.
Excellent. Thank
Can't
you.
wait.
Thank you, both Mark and Dr. Ellis. Kristen Comstock on our team has been managing Q&A. Kristen, do you want to start those?
I'm trying to manage. Yes, we've got a lot of questions, so I'm going to go ahead and get going here. If by any reason, if we don't cover, a lot of the questions that came in, I believe were covered, but some of them I'll just have Mark, most of them are for you, clarify. If your question does not get answered, you can email Julie Cole or Kendall Capitan or even your rep, and we'll somehow get your question and get it answered. Okay, so there's still some questions around the point of service, and for the 02 and the 11, here's one. If a physician is doing telemedicine from their office, so the physician's office, would you still use the code PO, the 11 or the 02?
What's the pair?
So, yeah, that basically the place of service 02 is really more about stating that it was a remote visit. So for Medicare, it's about where the patient is, not where the doctor is. So that would be a 02 as your first choice. If the patient's at home and the doc is at the office or at home, you would still use 02. Now, some of your private payers, as I mentioned, are not capable of processing 02, and they're asking you to use place of service 11, even with those remote visits, and instead indicate it was telemedicine by using the GQ, GT, or 95 modifier on the CPT code. So hopefully that helps.
Perfect. So then there's questions also around the topic of the 9921X, so the E&M codes that are typically in-office codes. Can you still bill that if you, what are the requirements around billing that? So do you have to have video, and then do you have to have video for the entire appointment? What if something happens? Or if the patient can't do their end of the video, how does that work around using that E&M code?
So I think both Dr. Ellis and I talked about that, and hopefully we cleared that up, that, you know, really the intention is to use audio-visual, document that you did your best on those things, but if all you can do is the audio, then the spirit of this is about patient care, and as long as you provide good patient care, then go ahead and build those codes even if you don't have the video. Ellis, do you want to add anything, Dr. Ellis?
No, again, we're talking about the care of the patient first. So take care of the patient. Now, how do you really document it? Is just as you always did as an office visit. As far as the patient having just audio, you got to take care of the patient first, and you've made a good faith effort, and there should be no complaint from any of the government regulators, including this one office that I'm forgetting the name, that really watches over HIPAA. I'm just not at all concerned about that. Patient care trumps whatever other agenda they may have. Now, legally, you want to be sure that you document it as best you can, and I agree with what Mark said. You should try, and if you can't, you can't. And I got to tell you, I am calling patients, they're answering the phone, I say, we can do this video, and they go, I don't want to do it video. And so they don't want to. You know, now some people do, but most people don't, and you got to take care of the patient.
Perfect, thank you.
Just document that the patient declined.
Also about level 4 specifically, a physical exam. What is the example template to use for a physical exam to get a level 4 office visit?
I think you're going to have a very difficult time getting a level 4 physical exam that's really meaningful for a new patient visit. You know, that may be saying it a little lightly.
Keep that in mind.
I mean, I actually probably should go back and say, I don't see how you can do it, but I'm sure there's somebody out there that's figured out how to do it all. But I think realistically, you know, that really is not a really achievable or in the end, you know, one of those things that's ultimately where you should be looking for. If you've got the time that you've spent to bill a level 4 for a new patient visit, then use time. But otherwise, you're probably going to be at a level 2 or a 3 for your new patient visits because of the physical exam. And then remember, you don't need a physical exam to bill a level 4 or a level 5 established patient visit. It's only 2 out of 3. So your established patient visits are a different story, but the new patients, be reasonable. In the end, if Medicare starts to see that things aren't going well, then you can bet they're going to react. As long as everybody self-polices and behaves and really focuses on patient care, we're going to be fine. I think that hopefully you've heard that again and again on all this stuff, that it's patient care trumps everything, and really do your best and do what's right. So that's what I'll leave it with that. Dr. Ellis, anything to add?
No, you nailed it. Thank you.
How frequently can you bill for a telemedicine visit?
He answered that.
It's funny. I asked that same question of Mark. And the bottom line is, these are office visits codes. So the real question is, how often can you see a patient in the office?
Ding, ding, ding.
And we all know that that's based on medical necessity, which Mark had told me, and that's really true. And if you need to see him back the next day, you're seeing him back the next day. Although, ask yourself, do I need to be seeing him in the office 5 days in a row? That doesn't make a whole lot of sense.
Yep. Medical necessity. Yep.
Here's a question related to the telemedicine platforms. Please explain the importance of a BAA. I signed up for Doxy.me, but was not asked to sign a BAA.
You can generate that for free within seconds through Doxy.
So technically, as you know, with everything you've done in the past, the BAA is really something that allows you to transact information or send information that's HIPAA.
I posted a specific graphical step-by-step link on how to do that on Doxy. Look it up in the discussion.
Transfer that information to those people who are legitimately worthy of receiving that information based on some financial relationship one way or another. And you have them with your clearinghouses and all of those things.
The problem is the person asking the question is probably not a member of the Thriving Urology Practice Facebook group.
Access to that information.
That's the problem.
Right? So it's stored encrypted on your servers and not on theirs, or the information is never visible to them. There may be, that may be an area where they think they don't need a BAA. I don't know, Dr. Ellis, are you using Doxy.me?
We have used Doxy.me. We have used Zoom as well. I don't believe we have a formal BAA in place.
Oh my gosh. Wow.
Yeah. So it may be that since they're not storing the information and the information is encrypted during transition, they legally have decided they don't need a business associates agreement with you. And that may be why they're sidestepping that. I am not an expert. I'm not a legal guy on those things. We've always been ultra careful and get BAAs with everybody, need them or not. But it may be that that's not an issue at this point in time because of the relaxed ruling, and that essentially Doxy.me isn't capable of pushing through all of that. Or it may be that, in fact, they never have access to the data and it's always encrypted and they don't think there's one that's needed.
No.
So I'll leave those two as my opinion on those.
I'm texting Mark.
Ultimately, if you have access to legal staff, I'd get that, and I will do some additional research on that to see if we can put some information up on our website. Which we do have a lot of information going through on our website. And I don't know, Julie, if you're providing everybody on the call with potential websites that they can access.
We will send out a bunch of websites, including yours, Mark, which has been very helpful.
I can just throw in, because I'm reading from a document, the Office of Civil Rights, which is about the enforcement. They will not impose penalties for non-compliance of the regulatory requirements.
But think about it afterwards. Think long term.
The rules for
not just during this crisis.
Again, so long as the providers have behaved in good faith provision of telehealth during the COVID-19 national public health emergency. So right now they have relaxed, and they really are relaxing right now. But as everyone uses this as a platform to incorporate telehealth into their practices 6 months from now when the emergency is over, then you're going to have to go back, I'm sure, and dot the I's and cross the T's. Right now, they're telling you that they are relaxing so they can get the patients cared for in their home without getting exposed to the virus.
All right, and I'll add, I just got a text from one of our friends in the universe out there that's using DoxyMe, and they indicated that you can actually generate your own BAA within the DoxyMe program. So you may be able to look around within those programs and generate your own BAA and get that executed as well.
Gotta love technology. Real time.
Several of those comments came in, so thanks to you guys too. Okay, there's a couple other questions around Dr. Ellis. How long are you making your telehealth appointments?
10 minutes.
I'm embarrassed to say. The truth is I'm making mine a half an hour, but that's also because of all the other responsibilities that I'm sure you all know about. Well, I will spend roughly 15 minutes on the phone. There's so many more minutes of documentation. Then there's the staff that's lining up that wants your attention. Then there's 2 other people that have texted you. And while you're on the phone, there were 8 or 9 more emails because we are in this time of need. So I am making them myself every half an hour just to get the rhythm going. But I can see it'll probably closer to 20 minutes once the dust settles some.
Got it. Okay, thank you for that. Mark, there's a couple of the questions around the 99421 to 423. Is it cumulative, the time? Is it cumulative, and is it billed after multiple visits or billed after each telehealth interaction? And what is the RVU value?
So the 99421 and 23 are really, there's the interactions that span a 7-day period. So those are codes that typically you would bill over, an encounter that took up to 7 days. If you have somebody that's kind of ongoing, and that you could potentially do that once every 7 days because there's so many interactions. So you would essentially not necessarily split them up by encounter normally, but you would if it didn't span more than 7 days. I hope that makes a little bit of sense to you, that, it may be an encounter that lasts 2 days, and then, 2 weeks later you have an encounter that lasts 2 days. That would be 2 separate 9942 codes. But if you had somebody that was a running 14-day encounter for whatever, you would bill it once for each of those 7 days. So hopefully that gives you a little guidance there. Now, RVU-wise, I didn't actually look at the RVUs. I can try and pull those up. They are the 99421 pays very similar to the G2012, which is about $15 nationally for Medicare. And the 22 pays about 30, and the 23 pays about 50 nationally. And I'm looking up just give me a second to get my coding today fired up. All right, so RVUs, work RVUs are 0.25 with a 0.43 total for 99421.
Not really worth your while. That's the bottom line. Let me cut to the chase for you.
The 99422.
Tell you what, Mark, while you're doing the math, I'm going to go back to the last question. Someone asked me how long I do my visits for. They're 30 minutes. Now, that obviously there's not enough time in the day, but my surgeries are also canceled, and I have blocks of time now where I can spread them out. And again, in reducing foot traffic in your office, your doctor can be doing this from home, so you can limit the number of people that are actually showing up. So it can work, and you can maintain your schedule. Mark, was that enough time for you to do the math?
Yep. So
Good job.
yep. So the 994. Thank you. The 99422 is a 0.5 work RVU and a 0.86 total, and the 99423 is a 0.8 work RVU and a 1.39 total.
Excellent. Well, thank you both, Mark and Dr. Ellis. We greatly appreciate your advice, your expertise. We will be, again, we did record this broadcast, and we will be sharing it out with everyone in case you want to listen again or share with someone who is not able to join live. So thank you, Dr. Ellis. I know you have telehealth visits to get to.
Yes.
So with that, have a good afternoon, everyone.
I wish you all well.
Julie, and I wish everybody well, and thank you and Medtronic for allowing us to do this.
Good work.
Absolutely. Thank you, guys.
Bye-bye.
Thank you.
All right, that concludes the Medtronic livecast of Experts Roundtable on telehealth and telemedicine in urology during the COVID-19 crisis. A lot of things were covered, and as soon as we're done with this, whenever I have time, I will render this, cut it up, chop it up, and upload it to YouTube and share it under John Seelan, MD. I've run multiple channels on YouTube, so that'll be one of the channels. And if you're watching this on the Thriving Urology Practice Facebook group, I will put that link in the video description as well. Several things. Number one, modifiers for E&M visits. It's going to be all over the place when it comes to submitting your claims. It sounds like not just the 95 and the GT modifiers are being used, but also GQ, Gulf, Quebec, is also being used to submit claims. And let's see, copay waivers. You can Medicare is saying that you could waive HHS, Medicare. They're saying they're going to look the other way. They allow you to waive copays. I'm not sure if they are going to make you whole, meaning are they going to cover the copay, or are you simply going to get the reduced, whatever the 80% instead of the 100% of your fee schedule? So that is not clear to me. And also, Dr. Ellis said that he claims he makes his appointments at 90 minutes, or he calls or have the patient expect a call from the physician 90 minutes prior, and the telemedicine visits are longer. I'm going to respectfully disagree, and I know there are other members of the Thriving Urology Practice I've spoken with. They also disagree. If you plan your patient care visits using telemedicine the same way that you would do an in real life IRL patient visit, meaning your financial people contacts the patient, and I know it's a couple of extra phone calls. Your financial people contacts the patient, collects a copay, update demographics. Your medical assistants update past medical history and review of systems prior. It could be a day before. It could be the day of. The way we do it here is the day of the encounter. The medical assistant, or the day of, or the day before. The medical assistants will contact the patient. They have plenty of time. Contact the patients. Number one, update the history. Number two, check if it's a first time that the patient's using telemedicine, verifies with the patient that they are all set up. The cameras turn on the platform, the microphone is turned on, so there'll be minimal disruption when I get to the patient. So the patient is not waiting online. These are discrete phone calls made to the patient, and then I'm simply taking care of the patient like I would in real life. I'm taking care of the patients efficiently using the telemedicine platform as if I do in the office in a very, very efficient manner. So I don't quite necessarily agree that it takes longer, and I know there are people, urologists, in the Thriving Urology Practice Facebook group. I've spoken with you. You know that it does not take long. You and I both agree that it does not take longer, and it is just as efficient as if you're seeing them in real life. And again, this is, like I said, but at the very beginning of the program, it's really a reflection of how you've always practiced. If you always have been working on honing your workflow and running things efficiently, this is a very, very minor blip on your radar, and you're just making a very, very small transition to telemedicine. This is not a big deal. It has not been a big deal to us. Let's see. Some payers not Medicare. Okay, some payers are allowing the billing of telemedicine visits without engaging video. Now, that's going to be payer dependent. That's going to be state dependent. But like Dr. Ellis and Mark said, it's really the spirit in which you are engaging in this behavior, this type of encounter, meaning you tried. I had a patient yesterday who just could not figure out how to turn on his camera. So we did the visit via telephone only. And I simply documented, again, the key is to simply document it in your chart that heroic efforts were made to have the patient turn on his camera, but unfortunately, the patient could not do it. So this is the first patient ever for us that he could not turn on his camera, but audio worked fine. Bottom line is, good faith effort is being made by you during the COVID-19 crisis. Document the telemedicine consent. So telemedicine consent, document that in the chart. Number two, you made heroic efforts to get the video portion to work, and it did not work. And go on, build the 9921X E&M level and move on. What Mark said also on the E&M, I just have to laugh. I mean, you see me laughing in the background in the video. Again, this crisis is simply magnifying the utter poor understanding of E&M rules among not just just like a country, it's a whole nation. People don't understand E&M rules, and it is clearly being amplified in this crisis as you try to adapt to telemedicine, telehealth. Dr. Ellis mentioned that he is at approximately 80% capacity, which is great. We are not. We are much, much lower, and that's and 70% of revenue is going to be the anticipated hit, which is great. Mine will be greater because I'm seeing mostly new patients. I try to cure my patients so that they don't have to follow up, and my follow-ups, if the primary care doctor can refill medication, a BPH medication, I'm not seeing that patient, and that's been my practice. So I will be impacted much greater because of the way I practice, the practice pattern. So your practice will be different if you are doing a lot of things, a lot of follow-up, established patient follow-ups. Your revenue stream when you convert to telemedicine will probably be a little bit better than someone like me who dispositions the patient and tries to not to have him or her come back to the office over and over, to the surprise of many patients. What do you mean you don't want to see me back? I've cured you. You don't need to come see me. If your primary care doctor sees that you have a problem, then come back and see me. So anyway, that's been my practice philosophy, and I'm going to continue doing what I'm doing because doing the right thing is always the right thing. Okay, legal aspects of telemedicine. Dr. Ellis kind of mentioned that the physician can be at home performing these telemedicine visits to promote social distancing, etc., decrease foot traffic, meaning decrease human-to-human interaction. You have to be aware that there are legal aspects. Now, this is billing, coding, this is great, logistics, that's great, but when it comes to the practice of medicine, there is very, very little interstate reciprocity when it comes to medical licensing, meaning if I'm in Hawaii taking care of a telemedicine code and taking care of a patient via remote telemedicine, that is medical malpractice because I do not have a license to practice in Hawaii. If the patient is in Hawaii and I'm in Arizona, I have a license to practice in Arizona, but the patient is in Hawaii. There's no reciprocity between Arizona and Hawaii. If I provide that medical care, that could be construed as medical malpractice. So you have to, it's great. We're talking about coding, billing, logistics, but I'm very risk averse. So you need to think about that as you progress through this telemedicine journey. Lastly, business associates agreement. Yes, Medicare, HHS said that Health and Human Services and the Office of Civil Rights, they relaxed the rules. During this COVID crisis, you can look the other way when it comes to getting a BAA and use non-public facing platforms like Skype or Apple FaceTime or Facebook Messenger video to conduct telemedicine visits. However, you should consider getting a BAA. Doxy.me, if you are a member of the Thriving Urology Practice Facebook group, I made a specific post with pictures showing you where to click to get that BAA. It literally takes you seconds to generate that BAA between you and Doxy, both using the free version or the clinical or the professional version of Doxy. You can generate that BAA within minutes. There's no excuse for you not to have that. You should consider doing this for the long term. This COVID crisis and telemedicine is a game changer. We are no longer, going forward, I bet most of us will be continuing on with telemedicine visits and increasing our telemedicine visits, because I have long realized that so many visits can be done remotely. And if you have this is not an endorsement of Doxy.me. I'm not paid by Doxy. I don't have any ownership interest. But Doxy.me, I'm able to show the patient on the screen his or her biopsy results, urine culture, lab results, and I'm able to send the result via Doxy.me in a secure fashion using the platform. So that's all possible using the paid version of Doxy.me. You should consider doing that. Again, not an endorsement. I'm just telling you my experience. Again, if you have any questions, please leave them in the comments below. I will try to once I upload this to YouTube, I'll put the link in the video description of this live broadcast. Again, thanks to Mark Painter, Dr. Ellis, and Medtronic for hosting this webinar. Really, really appreciate it. They don't know that I'm hijacking it, but I've live streamed it to have a greater reach, and hopefully it helps some of you. Take care, stay well, social distancing, hand washing, proper hand washing, not just hand washing, proper hand washing, very, very important. And then coughing into the antecubital area, and remember to not touch your face with your fingers or with your hands. Don't be a vector. Stay well. Bye-bye.